the primary care work group. The perfunctory announcements that the meeting is being recorded has already been made. I'll turn it over to our staff to do an introduction of who's on the line, and excited to start this meeting. Go ahead, Nene.
Thank you so very much, Ben. Good evening, everyone. Thank you for joining the meeting this evening. We would like to remind everyone, as Ben mentioned, that the meeting is being recorded. Please contact the MHCC team with any technical issues. We sent an email on Friday with the team's contact information. As a courtesy to others, please remain on mute when you're not speaking to reduce background noise. Staff may mute you if there's a lot of background noise coming. You can also mute and unmute yourself by using the small button at the bottom of your screen that looks like a microphone. The meeting facilitator will sequence speakers and may also call on people to ensure that we have a wide range of perspectives. Please raise your hand by clicking the raise hand button under reactions at the bottom of your screen to ask a question. Another option is to enter your questions into the chat box. Before we begin the meeting, I would like to recognize the work group members who are attending the meeting today. I see Dr. Digarala, Mr. Chad Pearman, Dr. Ishrat Rafi, Dr. Bernstein, Dr. Marstella, Ms. Karen Lamb, Ms. Laura Russell, Ms. Ramanathan, Dr. Khanna, Ms. Nora Hovan, Mr. Ron Gresh, Dr. Russell Lewis, Dr. Sarah Conway, Ms. Tracy DeShields, Mr. William Henderson, and I believe that those are all the work group members we have participating today. Is there anyone who have missed who would like to introduce themselves? Hearing none, I will now turn the meeting back over to the MHCC Executive Director and Work Group Chair, Mr. Ben Stephan, to make opening remarks.
So again, welcome everyone. I also want to be sure to recognize and welcome Vinayak Sinha with Friedman Healthcare. Vinayak has been working with us for a couple of years on our project management office initiative with Friedman Health, particularly focused on the collection of APCD data, as well as the development of a protocol for collecting information on non-fee-based reimbursement required of MHCC as a result of passage of the what's known as the Care First legislation last year. In addition, he's also been engaged in the Herculean effort of putting together something we abandoned about a decade ago called the State Health Expenditure Account. So he's really well-versed in many things that are going on in Maryland, and his other portfolio of services across other states make him ideal for helping us out today, because his colleague Mary Jo Condon is not available. Welcome, Vinayak, and hopefully I didn't give you too much of a history before you've had a time to lead us through some of the documents today. Just very briefly, I'm going to walk through what we're going to be discussing today. Melanie Cavalier is going to walk through the work plan and show our progress momentarily. And then we're going to have a rather lengthy discussion on the principles of for defining primary care. You should have gotten a matrix, and I hope you've all had a chance to at least go through the matrix once. It includes 8 major principles that we're going to discuss today. I purposely have told the staff not to read those cells, summarize them. But my hope is that everyone has had a chance to look at them and think about them, because they are really the essence of the next hour and a half. And if you want to do a little cheating, glance at them now, but hopefully that's not going to be necessary. we will be trying, our goal today will be to try to reach some consensus on, for each of the principles, the focus of where we want to land in terms of anchoring ourselves to these principles. We won't be taking votes, but we will be focusing on building consensus. That doesn't mean that we expect unanimity, however, and we do think during the discussions we will hear different perspectives on each of these principles or dimensions of measuring primary care. So I really want to now pass it on to Melanie Cavalier to walk through where we are in terms of the work plan. But want to remind everyone that this is a public and open meeting. We want to encourage the utmost participation we possibly can. And if we don't get it, I will be calling on you. And if I don't get it, David Sharp will be calling on you, and you know what that means. So pay attention. So go ahead, Melanie.
Thank you, Ben. Next slide, please, Nina. So I'm now going to review the work plan activities for May through March. So I'm just going to start out with the 2 completed items. So at the end of last year, the work group members responded to the framing questions to inform a shared vision for primary care. And then in the first quarter of this year, we held meetings to develop an approach to track progress towards achieving the vision. So today in the square that's highlighted in yellow, we're going to discuss the principles for defining primary care spending. In the one below it, at the March 27th meeting, we plan to review proposed models based on workgroup input. And then at April 10th, we're going to aim to identify a code set. Next slide. So I'm going to go over at a high level what we're going to discuss today. So we're going to discuss the principles to define primary care that fall into 2 major categories: framework and methodology. The framework principles include the purpose of measurement, the number of definitions, and geographic alignment. The methodology principles will be to include or exclude certain services or providers, prescription drug spending in the denominator, and non-claims-based payments. So I'm now going to turn it over to Vinayak to review the principles in more detail.
Sure, thanks, Melanie. As Nina pulls up that document, just wanted to say hello to everyone, and it's a pleasure to be with you all. The primary care definition is always one that is pretty exciting for folks because there are a few different things to consider, as well as we get to kind of think about both the policy side of things and what we hope to achieve, as well as some of the data side of things. And so we're going to get into some details here on that. This document that we'll be working through today has a list of these key principles as part of developing the definition for primary care spend. This first section really thinks about a framework and helps us think through, what we should be thinking about as we talk about the more nuanced pieces of the definition. So to get us started, what's the purpose for measuring primary care spend? Why are we here? As we look at this table, there are a few, the table is laid out in a certain way where we have on the left side in the first column some discussion categories, and then a few different approaches that Maryland can take in terms of defining primary care spend. Up here at the top, we're talking more about the framework and some approaches there as well. None of these approaches are, just one column straight down the document today. For any of the rows, what we might call the rows here, these discussion categories, you may choose, an approach 1 for number 1, but an approach 2 for number 3, or a 1 for number 5 as we go through the pieces. So don't necessarily think of it as, a singular column approach, but rather each approach for the discussion category is unique and can be taken as you wish. And then we'll also be walking through some kind of key considerations and trade-offs as to why we might choose one approach or another. And as you read through these and as we discuss them, I encourage you all to think about, what makes most sense for the Maryland environment, what makes sense for the vision for primary care, as well as where we know care is going in the state, including population health goals. Some important things to kind of think about as we go through each of these discussion categories. Any questions on that before we move into some of the detail here?
So Vinayak, one thing I think might be helpful and to give some relief to people who didn't have time to look at the matrix ahead of time, let's give everyone like 2 minutes to flip, if you haven't looked at it, to flip through the categories quickly, because sometimes you may look at, as we go through 1 and 2, you may come to 6 and 7 further down and say, well, if I thought about that ahead of time, on my perspective on these initial categories might have been different. So I'm going to give everyone about 1.5 minutes, 2 minutes to just flip through the matrix that we put together, if you don't mind. So,
Ben, I just wanted to know that Dr. Barr has his hand up.
yeah, Dr. Barnhart.
Hi, Ben, it's Michael.
Oh, Dr. Barr. I thought Dr. Barnhart. Who is Dr. Barnhart? But I gotta fake it. So Dr. Barr, of course.
No worries, Ben. Thank you so much. And I thank you for the introduction. You mentioned we can combine different approaches in the columns, but within a row, is there an option to combine approaches?
A little bit more difficult. Those are fairly distinct. When we actually look at the code set, which we'll do in the next few meetings, then you can start to pick and pull, okay, some of these services, but maybe not all of them, but not necessarily at this stage.
Okay, I'll raise a point when we get to the right time where I think it might be helpful, but go ahead and let's just go through the exercise.
And I think Dr. Khanna has a question comment as well.
Dr.
I
Khanna,
have a
go ahead.
clarifying question, Ben, for you. So when I look at this thing, it's not immediately obvious to me if we are developing this with the idea of bringing value to other specialty colleagues. It seems to me like, I think as a primary care physician, that I would like to see more spend so that we can manage our rising risk patients in a more comprehensive manner. And I don't see that on there. So I'm just thinking, should that sort of rationale be a part of this document, or is this not the place for it?
Let's put that on the whiteboard as a point to discuss as we go through the matrix. I think that's, I think in a couple instances with behavioral health and OBGYN services, we do expose that, but I think that is, those two areas are areas where there's already evolving thinking on better integration, but more broadly, I think we should discuss it as we move through the matrix.
And then Laura Russell.
I see Laura here. Go ahead.
Hi, good afternoon, everyone. The question that I had is related to the pillars document that we reviewed last time and how that marries up to this document. As I recall, the pillars document was pretty detailed and got to some of the, services that we believe primary care is. So I was wondering if someone could explain that connection.
Well, I'm going to explain it once, and then I'll let maybe David or Melanie chime in. So think about this. Think about primary care as a matrix, or maybe a Rubik's cube. And we looked at it from one dimension last time, and we're trying to rotate our assessment of it from a different but not unrelated perspective today. So I think they fit together, but you're right to raise a question. Do they fit together? David, do you have any more to add?
Sure. I think Ben's characterization of it is perfect. It's that what we did was say, what are we measuring? What do we want to measure from the pillars as it relates to primary care once it's defined? So we worked in a subgroup to say more broadly what are the elements of what we might look at? And here we're saying, okay, what is the definition? And then the two get tied together.
Thank you, David. Does that help you, Laura?
One recommendation that I would have is maybe to do a crosswalk between the two. Once we go through the discussion today, make sure the elements that the work group recommended are incorporated.
Absolutely, that's absolutely.
Sure, that's fine.
And then Sally and
Sally Ann, do you have a question?
She's clapping.
Oh, she's clapping. Okay. All right. I think our 2 minutes have been exhausted. So then please begin.
Sure. All right. So as we think about, sorry, I'm seeing a hand come up.
Sally and Alvin.
Oh,
I'm
Sally
sorry,
Ann,
that was a raised hand, and I was trying to unmute myself. But David, Ben, when I look at the three approaches, some of them are seem mutually exclusive. I'm going back to actually Dr. Barr's comment. I think some of these could conflate.
And could I, Ben, could I make a point here that, just to go back to Ben's point about some of these are good observations, we may want to whiteboard, because once we work through, when you see the further down on page 3, where the narrower and broader bar is, I think we'll definitely get to some of that, but it might be good to defer a little bit on that, and then till we get to the end, and if you still, then we can focus more specifically on your point.
Okay,
yeah, I think that there's something that can't be captured here, and that is the dimension of time. That starting out may not necessarily be where you want to end up. And for the first one, I do think they are mutually exclusive, but there could be a way in which I think most people would say they are mutually exclusive, but some of the intellects we have today may have some ideas on how they can be melded together, especially when you factor in time. Go ahead, Dr. Barr.
Well, I don't want to give Yannick his attempt to explain it, but that was the example, Ben, that I was prompting my earlier question. Because if you look at, if you want to use this as an example, is that okay?
Sure.
Just say, okay. So if you look at the approach 2 for purpose of measuring primary care spending, it's define goals for primary care delivery and whether spending is adequate for services envisioned. So you have to define the goals and the services that are part of that. And I'm thinking that, so all right, but how much are we spending in total? And maybe we're spending a lot of money somewhere else that really isn't to the goals and purposes of primary care. But that would mean looking at approach 3 as sort of the denominator, and approach 2 as sort of the numerator. That's how I was and that's the only one I thought where there might be. I agree with Sally. Most of them are mutually exclusive. That was the one that I thought might be something interesting to think about. So, and I'll stop there.
Thank you. And I think Chad is Sally Ann, I think your hand is still up, but I'm assuming you're going to put it down but go ahead, Chad.
Thanks, Ben, and thanks, Dr. Barr. If we're ready to just jump in number 1, that was pretty much going to be my comment, which is I would recommend or think we want to start with approach 3. That would be the basic understanding that I think we need to have to do all of this work, and then in time we probably want to do some refinements going with something like approach 2. But I don't think we can do approach 2 until we've done approach 3.
Chad, you could do anything. Come on, man.
All right. I love this lively discussion on the purpose piece in particular. What you all will hear me say a lot today, and I think you may get sick of it, is that these approaches, they lend themselves to what we call like a stackable primary care definition, where you may consider a base, and then you may also consider some additional provider types or services or other pieces of the definition that you capture data on, but maybe that's not what you base your target off of. So as you think about this, that means that you'll want to capture for the specific purpose section, you'll want to capture at least at the minimum the spending on core services for primary care as delivered currently in the state. But you may also, in addition to those core services, want to capture some data on where you think primary care should be going or is going in the state. So, we'll get into some specific categories of what that looks like as we go a little further down, but that may include behavioral health, maternal care services, as well as for minor procedures and other pieces. So we'll get into that discussion. And so that might be, closer to approach 2. And then you may have an approach 3 that says, okay, we have this list of who we have defined as primary care providers, and let's capture all of their spending. Now, the nice thing about this is you can use one of these approaches, especially as you look at approach 2 and 3, to say, okay, base primary care spending on core services is, X dollars PMPM. Let's call it $25 or $30 PMPM. When we also add in services for behavioral health provided by primary care physicians, it goes up by $1 PMPM. When we include services for behavioral health provided by behavioral health clinicians and primary care providers, it goes up by $2 PMPM. And there's a lot of reporting, and we'll reference this kind of throughout our conversation today, that does just that. It'll say primary care spending in the state is 5%, but when we also include this, it's 5.5% or 5.6%. And so there is the option to have a definition that is stackable, where you can report on the core set, and then as well as specific additional services that align with the vision for primary care in the state. And that helps, and the way to do that is to capture that data early and understand it, discuss it, and then say, okay, this is what it actually looks like in Maryland.
And Dr. Marcel.
Dr. Marcella?
I'm just wondering though, I think I'm hearing you suggest that approach 2 would be something where we would start with the basics, which are covered by approach 1, and we could layer in some additional things that we want to monitor or watch, which sounds good in terms of stacking. Approach 3, though, doesn't seem actually doable, given the fact that we can't measure some of the things that would actually contribute to that definition, at least according to the all primary care spending definition there. It suggests that some of it is not actually captured anywhere. So is that understanding correct?
I think that's a fair assessment. There will always be certain spending related to primary care that's not going to come through your typical claims data or your non-claims data. It's just, different and difficult to capture. Some of that spending may occur through, other nonprofit programs, through the Department of Health's programs that are different and separate for prevention for the uninsured population. Those are pieces that are not typically included in a primary care definition per se, because you can't hold folks to a target for those. But we do recognize that those are valid ways that money is being spent for preventive or general primary care for the population. Though it's a little bit difficult to say, okay, in our definition, we are also targeting an increase for those pieces of spending, as those are a little bit more unknown.
Other comments?
All right, hearing nothing, and then if we could walk through next, the next kind of discussion category, which is on numbers of definitions. Now, as the rest of our discussion after these 2 discussion categories will focus on, narrower definitions versus broader definitions based on all of these different discussion categories. Sometimes folks have just a single definition versus one that is stackable that I've, talked about a little bit already. And some states actually have multiple definitions. I think a good example here is often states that are doing cost trends work will collect their primary care data through a specific cost trends data collection on total healthcare expenditures. Now that definition may or may not be aligned with the definition that Medicaid in the state is using for primary care, which the Medicaid definition may not be aligned with what the commercial payers are using. And so that's where you may have multiple definitions, and you may have something that's slightly more narrow for a commercial population, for example, but slightly broader for a Medicaid population, since Medicaid does have slightly different coverage, particularly on certain different types of services that can really influence that equation as we look at the primary care spending percentage. And so this is something important to think about. There are a number of states that will collect it in a few different ways. I think Oregon is a great example of that. And it's useful to think about that based on the use case in the state. If there's work for sincere alignment towards a primary care delivery system across payers, then having an aligned definition, whether it's a single definition or a stackable definition, is sometimes a little bit more beneficial. Though when the purpose for the data collection and reporting is different from different state agencies or different work groups or payer types, then it can be useful to have a few different definitions for primary care. So that's something important to think about as you all consider how to define it. In terms of communicating those definitions, there are a few different ways and platforms to do that. The folks that are collecting and reporting on the data or regulating any particular stakeholder group will obviously want to communicate that very clearly, not just as part of the data collection process, but as well as part of any kind of regulatory efforts in relation to that. There may be efforts in contracting too. So if you have a specific primary care definition that's a little bit different because Medicaid chooses to contract with managed care organizations with certain primary care requirements, that could be a different definition. So those are a few examples as to when you might have multiple definitions and how you might communicate that successfully with all the stakeholders in the state. Any kind of questions on that piece?
Maybe it'd be helpful, Vinayak, if you talked about how for the states that actually have multiple definitions, can you give us a little bit more of the landscape on that?
Sure. I think that a good example of this is when a state, and I think Oregon is one of these states. Oregon has a target that is across payers, but is implemented in different ways. And that's because their cross-payer target to be achieved actually this year, so we'll hopefully get some exciting data and information on that soon, is one where the Medicaid MCOs in Oregon called CCOs, Care Coordination Organizations, they provide a slightly wider set of services for individuals who are enrolled in Medicaid than a typical commercial population would. And so while the percentage may be the same, what they actually look at as part of those services may be a little different. I think the example that I was providing a little bit earlier on when a Medicaid agency is requiring as part of their managed care contracting with administrators, so third-party administrators potentially with their payers, they may put into their contracting in a few different ways for the payer to propose a definition and reporting on primary care to make sure that they're hitting certain targets that Medicaid has for what they hope to have as their primary care investment, and that they would like their managed care organizations to be essentially implementing and executing. So in that case, you may have a definition coming from folks responding to a proposal, and you may also already have a state definition. In this case, some states are potentially moving in that direction. I don't know that necessarily those, the contracting details associated with those have been released. But an example here is Delaware, where there's a primary care definition that is used to evaluate compliance with the law for the commercial fully insured population. But there is also alignment amongst, state employees, which are self-insured in Delaware, as well as Medicaid, with the hope to increase their primary care spending and investment as well. And they're doing that through these contracting mechanisms with their administrators.
So what's the difference between the stackable and the multiple? The stackable is, personally more appealing to me because it does suggest that you are actually starting perhaps from a single definition for some cross-payer comparisons. That's probably fair, but there's recognition that certain dimensions of primary care are more important for one population than another. So I kind of like the stackable, which seems like a flexible multiple definition framework.
Then I think I would tend to agree. The stackable definition does provide stakeholders, particularly folks who are working not only with the data, but then looking at how they might report on primary care investment in the state, to include and exclude different pieces. And we'll continue to talk about that. The multiple definitions are often used when there are just different use cases as to why we're measuring primary care spend. If you're looking, for example, at primary care investment as part of a contracting effort, you may just be focused on a very limited set of primary care services and the investment you want in those services, rather than the additional stackable elements. And so you may just have a separate definition. Now, this is typically the case when it's multiple different organizations within the same state defining and measuring primary care. Not typically the case when it is one organization. The stackable is similar enough to the multiple definitions where you can say, all right, we do want to collect the data on a broader set of services or provider types or places of service. And we want to look at it from a more narrow lens when we only include certain providers and services, or we want to look at it in a stackable way. All right, what if we do include behavioral health? What if we do include OBGYN services? So I think you're spot on that.
Dr. Conway, do you have any thoughts on this?
Yeah, I tend to agree with the stackable. And when I was reviewing this, it feels like it gives you sort of the greatest flexibility in terms of adding on those different features like behavioral health and otherwise. And probably, while it might not align perfectly with every definition, I think can get you a close enough proxy as you're thinking about that. And even if we go back to the, is it before the, no, sorry, I lost my, if we go back to the defining the goals that we see in the first one, and if we go to some of the methodology ones later, it feels like the stackable gives us sort of the greatest opportunity. So that was where I was leaning as well.
Thank you. Anyone else? Dr. Barr.
Yeah, I agree with the comments that Sarah just referenced, as well as sort of the general recommendation. One other potential value of this is something we discussed in the work group, which is like different regions of the state or different circumstances. You're in an academic medical practice, you're in an FQHC, you're in a rural part of the state. The expectations of what primary care is in those settings may differ, and we may want to sort of look at it a little differently. So stackable, I'm taking would allow us to do something like that.
I think that's a really excellent point, Dr. Barr. As we think about sometimes the geographic differences in not only service provision, but also investment in primary care, it's useful to have those types of data elements as you're considering what the primary care investment is in those specific settings. Now, of course, part of the definition is the place of service. The place of service will let you know, academic medical center versus FQHCs, et cetera. Though a little bit harder on the actual geography of the state itself, unless you're thinking more specifically about having zip codes and zip code level data also being included and provided. Now, the APCD does have that data, and so would be possible, and we'd have to then maybe consider focusing in on the provider's zip code level data versus the member. And so, there's a little bit more nuance there as we think about how to actually collect and report on it. But I think that is a good point as well.
And we have another question.
Russell, I think you.
Right. So, and maybe we discussed this already. So I'm looking at the definitions. I guess we need to make sure that we standardize what is primary care. Like in the COMAR, it has a definition of primary care. So I just want to make sure that we don't get too far away from that definition. So how do you make sure that the definitions that we come up with or stack that make sure that they align to the COMARs, to the COMAR here? Because it's very clear what they consider primary care to be.
Interesting. I hadn't really thought of looking at state regulations, but a valuable point, I suppose. I mean, I think what we would say is that as a result of the work we're doing, I'd argue that we may need to go back and modify statutory definitions. We shouldn't, this is a work group that should not be, wed to a statutory or regulatory definition. That doesn't mean that some people may think, hey, that's absolutely perfect, or think, it's that definition has stood the test of time. We should do that. But I think the nature of the fact that we were directed to form this work group does strike me as the legislature's thinking that perhaps revisiting the definition of primary care, even in statute, even in regulation, might be something we consider. So it's helpful, but I don't think it's necessarily we need to feel as though it's compelling. That may mean, however, that some people think it's valuable, some people not.
Right. So the thing is, though, so you bring up a good point then, that as we evolve, then we want to make sure that we sustain this, right? And the only way we can sustain this is by making it law in some type of way. So if we decide that the definition we have created is more fruitful and beneficial, then we need to, at the end of this, circle back and have an impact on how the COMAR defines primary care. So yeah, so I do appreciate that vision.
One quick comment here. I think it's always helpful to be guided through that regulation. One of the things that we sometimes advise folks to think about is, the vision for primary care and the capabilities to provide that vision are continuously evolving in a state. It is sometimes beneficial to get a base understanding or set of what's included in primary care in a statutory or regulatory way. But having it focus on the fact that, those certain sets or types of services and or providers can be included in this definition, but the definition may not want to be limited to that exact set that is provided in the regulation or in statute, just because primary care is evolving, and as the investment increases, we do expect that the types of services at the literal CPT code level may change. That list may expand further as discussions in the state continue and as programs evolve. So something to think about. There are some other states that do exactly that they say, these types of services, including these following types, but not limited to just these types of services. And we'll get into those types of services in a couple minutes too.
Laura has raised her hand. You have a question or comment, Laura?
I would say a comment, just as we think about maybe, guiding principles here, I wanted to comment on number 2. I would vote for a stackable definition because we are under an all-payer model in Maryland. And from what I've seen, we're trying to create payer alignment across some of these programs. So I think a stackable definition creates the ability to perhaps foster alignment.
Thank you. Vinayak, let's move to
all right,
geographic alignment.
Next, when we think about geographic alignment, I want to caution that we're not necessarily thinking about the geography within Maryland here. We're thinking about alignment either nationally or across some other states or regions. So for example, the Mid-Atlantic region. Options here are to define primary care the exact same way a certain national effort may be defining it. For example, the Milbank Foundation has recently put out a report on a primary care scorecard. They have a couple definitions in there. One option is to potentially just align with one of those definitions. Sometimes there are, specific states that you may look to and say, hey, we've reviewed their code set for both services and providers and place of service, and it aligns well with what we're thinking. Why not adopt that? Makes it a little bit easier for comparisons. At the moment, I don't know that there's any state that has the exact same definition as another. We do like to keep tabs on what those look like. They will often, though, communicate and share experience on what types of services to include, what types of CPT codes or providers they might include, and what the rationale is behind that. So sometimes that's just a helpful conversation, and we like to bring that to a conversation. And sometimes there's just, no alignment with another state or or a national definition. And that too is okay. It's, you know, geographic alignment is not typically the reason why we think about defining and measuring primary care in a state. It's often driven by another use case, whether that's increasing investment or changing care delivery or something else. Any thoughts or questions on that?
So I think, you know, absent the federal government weighing in, I think you can chase the definitions around their, you know, the essential opinion leader here is probably, you know, CMS. They've signaled that they are moving in that direction, but haven't espoused the, you know, necessarily their definition, and maybe they are going to fall out like, you know, everyone else that they conclude they need a couple. But as you note, there's really not even a plurality of states that have centered on one definition. I think probably the closest is what came out of New England, the New England Coalition several years ago. Any thoughts on that, Vinayak?
That's right. So this is one of the things that gets quite interesting, where depending on, you know, the use case and what the national organizations are measuring, you may have something like the NACESCO report that is getting data from multiple states in New England. And this was a one-time report published a couple of years ago. Got data from a number of states in New England and looked at primary care according to a few different definitions, a more narrow definition and a broader definition, as well as really considering the piece of the primary care spending that was coming through non-claims data. And we'll get into that a little bit further, but it's true that you may have folks that are reporting on primary care spending nationally and including state level analyses. So for example, including what they believe is the Medicare portion of primary care spending in Maryland. And you may also then have your own definition and have a way to compare to those and say, well, our definition is a little bit different in this way, and therefore we are, you know, half a percentage point higher or lower, and this national report or regional report is telling me a little something different and interesting in relation to our own state and its data that allows you for comparison. But that doesn't necessarily mean that you need to align. I would also mention that, again, you know, these efforts where data is requested from multiple states and a regional primary care spend is published, those efforts are typically aligned in their definition, but not aligned with what those individual states' primary care definitions are. So for example, Massachusetts and Rhode Island are included in that NACESCO report that Ben's referencing, but Massachusetts and Rhode Island's own primary care definitions are not the same as what was published in that report.
So Dr. Bernstein has a question, and I think we have Dr. Garia is also on deck. So consistent with the start of the baseball season, please take a few swings there, and we'll start with Dr. Bernstein.
Yeah, I guess my, assumption and maybe non-intellectual sense of this is that we should align because we share the same goals and maybe aim for the same successes that another state has. That if we have this sense that a certain set of services have value to improve the health of the population, that's what we're aiming for. Less so comparison. It goes back to, I guess, what we were talking about in number one. What's the purpose of measuring? And I think I would reject that the measuring is to assess the adequacy, and so the alignment should go with the goals. And if we think the set of goals matches up, then that makes sense to align and use, but that would be the value in my mind.
Thank you. Dr. Guerra.
Yeah, thank you. I agree that we should, with Dr. Bernstein, that we should align with either a national effort or a multi-state effort. As was mentioned earlier, I think the comparison is really important. So if we have similar, if we're aligning and we have a similar definition, it makes it easier for comparison with a national effort or other state efforts. But I think part of it is, it also depends on how we end up defining it. There's other categories later that I think will determine, how we define it. And then I almost think like we should do that first and then decide about aligning with a national or multi-state effort, because then we can find the closest comparison rather than saying we're going to align with something. And then if we end up with a different definition, it's not going to be comparable. So I almost think that this should be a later effort, is deciding about whether we're going to align and come up with our definition and find what efforts are already there that are closest to our definition.
A good point. Dr. Marsteller?
Yeah, I was just going to think about out loud a little bit about why we might align with nearby states and or other sets of states. I mean, first of all, if we wanted to have Maryland perceived a certain way, we might align with definitions of states that we admire or that we think have a primary care policy that is to be envied, right? We might say, we're doing what I'm going to throw out Oregon is doing, or we're going to do what Massachusetts is doing, because we're very like Massachusetts or Minnesota or someplace like that, as far as how we think about primary care, how we care about primary care. So that would be one thought, although I think it's hard to assess broadly, whose policy we consider most like our own. The other thought that I had was that we may want to align with neighboring states in a case where there will be beneficiary movement from place to place, conceivably. Let's say if it were something like we were giving away, free jet skis, then someone might move from DC to come to Maryland because they want a free jet ski. Or other kinds of moving around for the benefit of certain policies. So if there were, for example, insurance benefits that were available, or if we had better primary care in Maryland, would that induce any other states or any other people to move around based on our lack of consistency with other definitions? So those were two thoughts that I had just for the group's consideration.
And Ben,
I think Nora, you also had a point, and then I'll respond to Dr. Marsteller after.
Sure. And I just wanted to piggyback on Jill's comment. I think if we look to some of the CMMI primary care type innovation programs, they may have some definitions out there for us to kind of look at and see. And then if we kind of start there and see what's out there with their primary care innovations, I think that may set us up to maybe have the comparisons with other states eventually. Maybe not off the bat, but something like that may at least be a way to approach it. That makes sense.
Yeah, just following on what Dr. Girola and Dr. Marsteller said, I think you can get caught in a sort of a circular thinking here. We probably need to revisit this particular dimension, as you suggested, Amar, after we've thought about what other components of care fall into the broader definition, because that may be controlling as well. But I kind of like the idea. We may not be able to come back to that today, but I think that idea of refreshing, it's not, these 8 dimensions are not to be evaluated sort of sequentially, but once we have gone through them all, I think you've tried to figure out what the package looks like. So I think that was a really good point. Other comments? I don't see any right now. I see Dr. Khanna. Sorry.
Hi, Ben. So I think all this discussion is really good. I mean, having some sort of definition. The only caveat I had on that is that we are in the Maryland model. We're part of the Maryland model. We have a demonstration model going on, which is clearly evolving into some unknown entity at this point. I think building in a little bit of flexibility might be a good idea. At least a method to revisit this once the MDPCP model goes away and the other one starts. And I also want to remind us that there's two types of practices in our state. The ones that participate in these various transformation models and these advanced models, and then those who don't. So there needs to be some thinking around how we plan to bring all these practices together. I mean, what is it that would incite them to function higher than they have in the past? And how would they be measured? I think they ultimately comes down to whatever they do, how are we recognizing their effort and how are we trying to reimburse them, perhaps?
Thank you. Good points. Thank you. Well, I think we're going to be revisiting a couple of these dimensions, but let's move on to number 4 for right now.
And I just make the quick comment that, states will typically consider these methodology dimensions that we're now going to focus on, and then come back and say, all right, are there other states that are also, in alignment with our thinking here? And how can we use their work that they've done to not reinvent the wheel and potentially align? So I think you all kind of were leaning in that direction, and that makes sense to me. So let's start off with looking specifically at services. So now as we look at the approaches, what we're looking at are typically on the left, on the first approach, you'll see something that's a little bit narrower and more closely defined. Typically, a narrower definition is accompanied by a lower percentage of total cost of care or total medical expense for your primary care investment. Also typically associated with a lower PMPM for primary care. A broader definition would be higher. That'll apply to the next multiple discussion categories. We'll start off with services themselves. We did talk a little bit about, what is the purpose of this measurement? Is it for a core set of primary care services that we all think of, or is it actually working towards a vision for a defined set of additional primary care services? And as well as, are these, then as we think of broader in approach 3, are we thinking, okay, well, we're defining these specific taxonomy codes as primary care providers, and then is it all the services that they provide? And so those are kind of some of these differences here. Now, as we were talking about earlier, there's regulation or statute sometimes that talks about what is included in primary care, and often they will include categories such as those that are offered here in approach 1. So office visits, preventive care, vaccine administrations, potentially home visits, and other pieces. And so that's what we think about as we think about the different types of services that are included in a primary care definition. And I'll just mention, here's where you really do want to align with your vision as much as possible. So what does the state of Maryland want primary care to look like? And therefore, what services should we collect data on? Again, another good part where I'll mention again, the stackable piece here. If you have these categories such as office visits, et cetera, and you want one of them to be behavioral health services provided in a primary care setting, that is stackable, and that's something that may be closer to an approach 2 rather than an approach 1. And again, also still different from approach 3. So interested in some of the comments and questions you all have.
So before we open it up, approach 3 would, as a rule of thumb, mean estimates of primary care spending would be how much larger than approach 1? Any sense of that, Vinaya?
So that's a good question. I don't think that there are necessarily any states that have decided and said, well, we're just going to measure all of the services provided by this list of particular providers. So I don't know that there's that much data out there on approach 3 itself. but there is considerable amount of data out there on what does it mean for a narrow versus a broad definition. And, that really does vary pretty significantly. These broader definitions that you might consider that are closest to approach 3 can look like, almost 15% of total medical spend is being spent on primary care. And then as you look at something narrower, you may be closer to 5 or 6%. And this is in the commercial market. The recent Milbank scorecard that was published just a few weeks ago includes this information from 2010 to 2020. And they do look at it by commercial, Medicare, and Medicaid payer types. As you can expect, there'll be variation across those. Commercial typically tends to be a little bit higher.
So I'm going to call on Chad first because he had sent me a text saying I wasn't calling on him. So the only way he could enter information is by chat. That's not the case. So go ahead, Chad.
Thanks, Ben. I appreciate the opportunity. I was just thinking, I think this might be the spot where we can, to Laura Russell's original question about where the vision and the goals of how you measure primary care fit in. And this might be our opportunity to identify what is advanced primary care services. So, approach 1 and approach 2 makes sense, except that it doesn't identify, there's no value, if you will, necessarily to one over the other. So if we can identify either through some of our goals, through other models, through Starfield, et cetera, what are the advanced primary care services? It allows you, again, you can stack it, but you can see what are base or core primary care services and what are the additional value-based advanced services.
A good suggestion. Thank you. Dr. Jagira,
You're on mute.
Thank you. I don't want to get into the weeds too much, but I had just some questions about, so for instance, like approach 2, where it says minor procedures and screenings, some primary care physicians may do some specialized services and some specialized, procedures that many would consider, oftentimes specialists would do, like skin biopsies and things like that. So that's one thing that I think most people would consider not primary care, although I guess that definition can be whatever people want it to be. That's one question. The second thing is about screenings. Is that screenings like, we're talking about like depression screenings, which are often done in primary care offices and are in claims data, or are we also including like mammograms and colonoscopies? Because that's, starting to get into a whole other field. So that's just my question is, I think some screenings like, depression screens, tobacco cessation counseling, those kinds of things are kind of like claims that are, or CPTs that are outside of regular office visits would be considered primary care. But, my question is just about, other screening tests and also how are we defining those procedures?
So Ben, if you don't mind, I'd love to just weigh in a little bit here because this is one of the key stakeholder questions that does come up. As we start to expand this definition and think about a slightly broader definition, why are we including and what are we including? So this is where the why becomes really important. The why here, for example, for these minor procedures, such as skin biopsies, et cetera, the why here may be that as a state, we're trying to incentivize folks to receive this care in primary care because A, they may get a quicker appointment, B, it may be cheaper, there may be a number of other reasons as well. But if that is the reason, if that's one of the goals of the state, then you do want to include that here to account for that provision of care delivery. And if there are investment targets that increase investment in primary care, let's reward that, right? So that is an incentive essentially to shift care in that way. In terms of your screenings, I think you're right. It is depression screenings. It also is screenings for things like social drivers of health. And what does that look like? And how do we connect folks through the primary care setting to additional social supports and resources? And so do we recognize that? Is that something that is being incentivized for the primary care community? And if so, let's potentially include it in a stackable definition, understand what's being spent on it now, and then potentially push care delivery to move in a way and say, we want to expand spending in this specific area.
So this is Sally.
Go ahead, Sally Ann. I have a couple people ahead of you, but you.
Oh, no,
spoke
go
first.
ahead. I'm trying to figure out how to do this thing. Okay, go ahead. Have the other people
Okay,
go ahead.
I'll start with Mr. Henderson from HSCRC. Go ahead, and then Nora, and then Dr. Ramathan, and then Sally Ann. Okay.
Thanks, Ben. I was just going to say, and I don't know if other data supports this, I have the impression from some analysis we were doing, kind of sort of an offshoot, it wasn't something we were looking at, that the use of the minor procedures by primary care particularly varied a lot by geography. So the rural areas tended to have more of the minor procedures with the primary care, presumably because they sort of less access to other kinds of providers. So I would worry about that a little bit if you only had approach 2, that you may not get a apples to apples comparison. It would appear you sort of artificially inflate the more rural areas. Now, I could be wrong about that. Like I said, I was just an impression I had. So that would be my one concern.
Yeah, I think, that's generally found to be true. Both the data and anecdote seem to be going in the same direction, that the scope of services provided in a primary care practice, say in Western Maryland, is quite a bit different than what would be provided in downtown Baltimore. I think I said Nora's next.
So yeah, and I just wanted to say for FQHCs, they're just gonna look a little bit different than what's being done in a primary care office. They're just, they are required to offer broader, more comprehensive services from a federal perspective. So I just wanted to make that point, and something that may be so part and parcel to the work they do with the screening. Like you're going to probably see more higher screenings done in a FQHC just because of expectations. So that may be one thing that we just need to piece out. And I appreciate that comment of an apples to apples comparison, but it's also FQHCs are set up that way because of who they're treating and the needs in their community, as it's been defined by just having high needs and the very nature of that. And then the last point I just want to make is, just because you have access issues to specialty care for our vulnerable populations, there is some more testing out at FQHCs about how to do e-consults, and take something as trying to get an appointment for a dermatologist can be very difficult for our patient population. So doing more with e-consults where our providers can do that next step, it prevents that additional specialist appointments from having to be made, but it's how they're working with specialists. So I just wanted to make those points to just kind of acknowledge that FQHCs can look a little bit different. And, as we talk about the definition, maybe just keeping those things in mind.
Thank you. Dr. Ramathan?
Hi, it's Meta. I'm not a doctor.
Okay.
It's okay. So the 2 points I sort of had to make was, one, when we start talking about screenings, I would wonder, again, we'll talk about this with OB, but are we talking pap smears as part of primary care? Are we, when we talk about screenings, is it just things that would be sort of leading a patient to a more specialist type of space after the screening, when we're trying to decide what would be included?
What do you think? What is your opinion?
So I think I like this idea of e-consults, because I do feel like, so I'm a midwife, and so I'm primarily in women's health, and I do feel like there can be a disconnect between what is understood from a primary care perspective versus this being what I do all day, every day. And I will see patients that have been referred after something's been started and been like, hey, that's not really how that should have gone. So I'm a little torn between where to draw that line, I guess is what I'm saying. The other question I had, or the other thing I was thinking about, is in terms of procedures, is one of the goals to prevent patients from urgent care visits and ERs, in which case some of those procedures that primary cares are doing, like, are they doing sutures? Are they doing, glue, stuff like that, that's keeping patients out of those sort of more expensive settings? Is that, do we want to include that to incentivize that?
So I'm hearing you say a broader definition you think has value.
I do. I think to a degree, but I think that I like having the having it coordinated with specialists sometimes being, I see a lot of value in that.
Okay. Thank you. Sally Ann has been waiting a long time, so go ahead.
It's okay. So my question was going to be, is there anything in approach 3 that you all feel would somehow be prohibitive? I like the idea of the stacking and including a variety of services, based on what Nora said and what Meta just said, my own experience as a primary care provider, where in a underserved setting is where you end up doing more than what perhaps a primary care provider in a private office setting would do. And I think it's very important that we get the broadest definition possible in the set of services, because I really do believe that there's more happening in the primary care offices, especially I do know FQHCs and some other settings than we're currently capturing.
Yeah, I think that's a good point. And the stackable could go all the way to the absolute end, which is all services. It also, I think, approach 3 is kind of close to what the Starfield definition was of primary care, which Dr. Barr and I learned well, partly because we were being beaten over the head with Barbara Shillelagh. I'll use that at the time, but definitely a very broad definition, in one of those earlier thinkers about this. I'll say no more. I'll ask Dr. Lewis.
Well, and Ben, I did some work earlier with Hopkins around defining primary care for developing some quality measures and stuff. And again, we used Dr. Starfield's approach. Is that what we looked at a number of them, but Starfield was the approach we ended up taking, being the most inclusive approach to take to define it.
Yeah. Russell?
Sure. So the one question is how do we calculate referral patterns into the PME calculator? For example, you've mentioned that if you do the core, the PMPM may be $5 versus we do approach 3, it may be $15. But the thing is that the phase 1 person may refer to a high-end specialist, whereas that's phase 1. But phase 3 may do the procedure themselves. So yes, it could be a slight increase in cost, but in the grand scheme of things, it's going to come out much cheaper because you're not making that referral. So how do you calculate that into the PMPM? Because if you just leave it as what the primary care physicians are doing, it's not going to give a true representation into cost savings or potential cost savings.
Yeah, I'll give a quick answer, and those referrals would not, count towards primary care spend, I think, by most definitions, but Vinayak may have a broader view of what's going on. Am I off base?
No, Ben, that's right. So the actual referral, once the services are then being performed by someone not categorized as a primary care provider, would not be included as part of that numerator in our PMPM or in our percentage of total medical expense. Though I think, Russell, you do bring up a good point in the sense that, when the definition is broader, you are going to have a larger PMPM. And if you are encouraging those services to occur in primary care, they may be occurring at a lower cost than they would at a specialist. Now, in approach 3, when you are including those types of services, you're accounting for the potential cost or the investment as part of the primary care definition in the numerator. You're also then not counting what would have potentially been spent at a specialist that would have been in the denominator. So your denominator in that case may be a little bit smaller because the cost for delivering that care is being attributed to a primary care provider rather than to a specialist, since it occurred in the primary care by that provider in a primary care setting. I hope that gives a little bit of context there.
Yeah, I just wonder, how do we use that data then? I mean, what would be the talking points when we produce the PMPM data, given that a primary care physician in approach 3 is providing a broad scope of services that, even though it gives the appearance that they're more costly, but in essence they're maybe generating savings. And how do you calculate and represent that savings to the audience? So in telling that story.
An exciting question, a slightly different analysis altogether. I think we want to be looking at the data in a few different ways, prior to incentivizing and paying for these minor procedures in primary care. What does that look like? When they were provided by specialists, you'd want to be looking at both kind of the utilization there, as well as the cost associated with that through the delivery of care at the specialist versus the primary care provider. Though very interesting, and things that we like to try to understand as we propose, what is the vision for primary care and how much does it cost to actually get there? That's more costing out that vision for primary care.
So the last commenter on this particular category, Laura.
So when we think about narrow or broad, I would recommend thinking about broader, because we would want to reflect the current landscape in our state. And in my opinion, we're a pioneer in some areas in terms of some of the health equity payments that we've started. I would also recommend taking a look at those SciHIS goals and how that might fit into how we might be incentivizing primary care providers to do certain things or offer certain services that might be different than the core set of primary services. So I think I would be split a little bit between approach 2 and 3 here.
Thank you. Yeah, so hearing kind of the general of the people that have spoken, I think my sense is somewhere between 2 and 3 is where most people came down. Some people 3, some people 2, but generally I think a fairly good sampling of people is this is one where I clearly think I hear people expressing opinions, which is great. So let's go. We've only got about 15 minutes. I'd like to get through a couple more if we can, and we'll tell you what's in store for you because you were so thoughtful tonight. But let's cover a couple more categories first.
Sure. I'd say that, starting off as we look at the set of providers defined as primary care providers in your definition, that will obviously greatly influence your primary care spending investment percentage, as well as, how that care is being provided and accounted for. I think these approaches here are fairly self-explanatory. In approach 1, you have what folks might consider traditional primary care. In approach 2, you have an expansion to a few more folks that do provide primary care services to their patients, but may not be traditionally considered that. And approach 3 is something we always throw out there if folks are interested in it, though we have not seen states where they say, hey, no matter who's providing it, if it's this service, let's just include it. And so that's essentially what approach 3 looks like there. Though we do want to provide you all with the option to consider that as well. Any thoughts or questions on that one?
Dr. Perman, please proceed.
Thanks, Ben. This is where I think the interaction of number 4 and number 5 come together, which is to say that in certain settings, particularly sometimes in rural parts of the state, but sometimes in other parts of the state, you may have people who are in approach 1, they're traditional primary care, providing a broad set of services, but you may also be looking at approach 2, where you have people who are maybe in settings or specialties that are not traditional primary care, but they're delivering primary care services. So that's where we have to figure out what is the overlap of the services with the provider, right? So you could have somebody with multiple specialties, somebody with cardiology as well as internal medicine, and delivering a broad set of services. And I think you need to be able to collect at least the primary care services that are delivered in that setting.
Dr. Conway.
No, I was lowering my hand. I think you know, we keep coming back to sort of the stackable opportunity here. You know, I do think it's important when we look at sort of OBGYNs and others who provide, you know, that there's an solidly an overlap in the primary care services there. So it does feel like you want to have a definition that at least on some level, even if it's like an outer ring, would include that level of care, and particularly because we think about some of the cervical cancer screening and other things that falls into both categories. So it seemed like we would want it there. I was really trying to struggle with approach 3 and really understanding the scenarios, and I think maybe Chad was touching on that, in which you would find providers who were not one of those things, who would be included within that catchment. So that's what I was gonna really ask a question. You know, what are we excluding with approach 3? It feels like a strange approach, but I just wanted to think of some clear examples. And my first mind was going to, you know, urgent care specialists, but they would still fall into potentially approach 1. So I wasn't really sure who we were thinking about in approach 3.
Vinayak, do you want to comment or you want me to?
Sure, happy to. So I think, you know, Dr. Perman kind of hit on that a little bit as well. When we're thinking about this, I think we're thinking more specifically about folks that are chronically ill and being specifically managed by their specialist, really, potentially not having much exposure to a primary care provider. And so they're likely receiving some forms of basic primary care or preventative services in addition to the management of their chronic condition from their specialist. You know, there potentially a few different types of conditions that lend themselves to that a little bit more. Again, it may not be a significant portion of spend, but possible.
But they also could be actually, so in that case, an oncologist, a rheumatologist, you know, a hematologist, all those things could actually be a very high expenditure group potentially, right?
So we want to specifically focus on those primary care services. So this is where we come back to that number 4 and say, sure, if we're counting these for these additional providers, it's only these services, it's not all the services. Otherwise, you know, you're kind of moving out of primary care slowly.
Got it. Okay, thank you. That's helpful.
So I do have some hesitation about, you know, including all providers, and even approach 2 does make me worry somewhat. I mean, by making all specialties primary care providers, you can ultimately eliminate your primary care deficits. And I think that one of the, perhaps not the main element of this exercise, is to make the point that we don't have enough primary care providers. If we make this definition too broad, I think the risk is from some that it looks like, you know, our primary care supply is adequate. So I think if you did go to option 3, you would want to, again, have a different definition of primary care provider workforce that is largely definitionally independent of primary care services, which can be done but might be quite confusing. Dr. Bernstein, and then Sally Ann has her hand up.
I think my comment is just an expansion on what you just said, is that we do have to give some consideration of the implications of these inclusions on the viability and accessibility of what we think of as primary care. In other words, if there's the risk that if we incentivize happening outside settings where most primary care happens, does that potentially reduce the desired shoring up viability, accessibility of primary care settings? So those are the implications that would be of concern. You could also make the case in the other direction that if you incentivize bringing things into the primary care home and there's not the resources to do that, would you take away from the accessibility of other primary care services?
Do you all feel the same way for OBGYN specifically? I feel like that's a reasonable test case for that, right? If we think about our FQHC colleagues, that's a core part of that service. If we think about childbearing age women, it can be very solidly their primary care provider. So I guess I just wonder in that unique case where that falls from your perspective.
So thank you, Dr. Conway. Sally Ann, one of our FQHC representatives, may be able to comment more directly on it than I can. Go ahead.
Yeah, no, I think that you and Sarah have made a good point. It's how do we capture what's occurring in primary care, but also identify it in a way in which that care is being provided by that's what we would term specialty care, being provided because there isn't any access. So I think Garrett County is an example where primary care physicians, specially trained primary care physicians, are doing the deliveries because at least as far as I know, there's no OBGYN in that area. So I'm just trying to figure out how we address the issue you raised, Ben, is that we don't throw everything into primary care and then not get a true picture of what the service needs are. And some of this is geographically driven.
Absolutely. Any other final comments before we move to number 6? Go ahead, Vinayak.
All right, sounds good. Okay, so again, as we look at number 6 and we think about behavioral health services and providers now, again, we're going from narrow on the left side in approach 1 to broader on the right in approach 3. Some states choose to exclude all behavioral health services. That sometimes is driven by stakeholder conversations where they feel like there may be, such a dearth in behavioral health providers that it may not be the right thing to include. Sometimes there are behavioral health stakeholders themselves who may say, hey, we want to measure this separately. Though we can confirm that there's only 2 states that are doing that measurement for behavioral health spending at this time. So maybe worth kind of a closer look at there. Though now we do see that a number of states that are measuring primary care investment include some form of behavioral health services in their definition, often aligning with what they see the vision for primary care to be, and whether that includes, as we were talking about earlier, base screenings for behavioral health, short-term treatments, etc. And so if that is part of that integrated behavioral health care delivery, then that is something worth considering and including in the definition. If it's not part of the current practice, is it something that's envisioned in the future in the state? And if so, maybe we should understand what that investment is now and then how it grows as primary care is incentivized to provide that type of care. And then there are some states who take it a little bit further and then also include certain additional services and provider groups. And here, as we think about provider groups, you can go as far as to say, psychologists and psychiatrists as well, though particularly maybe focused on certain services that they provide and not all of their services. Here we do see some variation amongst some states. Folks that do include a narrower set of behavioral health services instead of none at all, so that middle number 2 approach, do vary. What they include may vary from depending on the types of behavioral health services they consider as part of their integrated behavioral health care provision, as well as partly here to really incentivize the provision of this care in a primary care setting in a more coordinated way. In our column here, as we think about considerations and trade-offs, we do highlight Colorado because they have one of the more comprehensive definitions for integrated behavioral health as part of primary care. And so some considerations to really think about there. When we think about what this really means, what does this mean for primary care spending as a percent of total cost of care? When we think about those services, primary care type services in integrated behavioral health provided by non-physicians, the increase across payer type can really vary, but can hover around 2% for the commercial market, or almost up to 3% in Medicaid. And this is based on the data recently published through the Milbank Foundation's primary care scorecard. And then when you go a step further and you include psychiatrists, that increase is pretty significant, estimated, between 3 and almost 5%, depending on the payer type. So Medicare being the low end there at 3, and the commercial market almost at 5. So pretty significant in terms of what that means for your percentage of primary care spend as a percent of total medical expense.
So we're close to concluding. I want to try to get some work group members to comment if we can. I see Nora has her hand up.
I was just going to share. I think we have to start really thinking about behavioral health is primary care, and I think we just fall into the trap of separating it out, and we have all these things in Maryland that honestly probably don't work too well because we always consider it a separate thing. In FQHCs, there is probably a lot more behavioral health delivery, including MAT services and the combination of mental health and substance use. But I think if we don't get everybody included who is providing behavioral health services, we don't have that true picture of what's being provided. And then back to Ben's point about what's really needed here, because we probably don't have enough. And maybe this is a stackable approach of who's doing what, but I would be nervous not to have as broad amount of data as we possibly can in the behavioral health realm.
So I'm going to call on someone else that might have a different opinion. Dr. Khanna. She may have had to drop off. Dr. Bernstein.
I think I would definitely say that primary care is behavioral health in the broad sense. My only concern with approach 3 is it seems to be as it exists now, a very vast entity, and needs to be expanded our spend, but I think it would be a big bucket to try and fill with our expansion and would lessen potentially some of the other goals and components of primary care. 2 seems more appropriate to me.
Dr. Barr, are you still on? You have any thoughts? He may have dropped off too. I think that the point that Nora made is an important one. I agree with Dr. Bernstein. I do think, and I'll use this, the dimensions of mental illness are really wide. And I would be careful about defining all behavioral health treatment as primary care. I think we have to have a more nuanced and stackable approach. I think primary care embedded in a primary care practice seems appropriate, but for chronic, severe behavioral health services that are not appropriately treated from the environment of a primary care practice, it's hard for me to think of that as counting towards primary care. And I think it's, in part a bias against behavioral health. I have used this example a few times, which is if you count up the number of APR DRGs that relate to behavioral health versus physical health, it's a ratio. There's about 60 or 70 behavioral health APR DRGs, and William will tell me, I think 600 APR DRGs or 500. And the scope of what we consider behavioral health can range from mild, moderate, severe, but we don't have the number of diagnostic complexity to capture all that as well as we do with physical health. And I think, as we think about this, we have to recognize that we can't solve all the problems necessarily of access to behavioral health services by lumping it into primary care. Anybody want to react to that?
Maybe there's a way just to do the, define it as outpatient behavioral health care, as opposed to not residential treatment beds, not inpatient, but what's really being provided in an outpatient setting.
Chad, do you have any thoughts? It looks like you about ready to raise your hand.
No, I would agree with that comment.
Okay.
Happy to just add one piece of context there. Typically, as states think about integrated behavioral health or behavioral health as part of a primary care definition, it is the outpatient visits. And so that does align with how other states have been thinking about this as well.
So we are at time. It's been really, I think, a good discussion. I really think we've had some good insights into these categories and how we might refine our categorical definitions. I also think that the point that Laura made at the outset, that there's a crosswalk that's needed between what we talked about last meeting and what we've accomplished today. And I think that there is going to be a need for an additional meeting to cover the last three dimensions, as well as we probably want to go back and do a refresh and consider the progress we've made as we refine all of these last three categories. Is that possible? Melanie, or can you outline what our options are in terms of a follow-up meeting to deal with the remaining categories?
Yeah, absolutely. So we have a meeting scheduled for March 27th, and based on the progress that we've made tonight, what I would recommend is that we continue through this journey. We also have one calendared for April the 10th. So I would say that we may recommend to use that meeting as a follow-up of all the discussions that we've had. And before we move, it'll kind of be a summary, I guess, of the other two meetings. So that's what I would say right now. I don't know if David agrees with me on that, but that's what I would recommend that we do at this point. And also, to Laura's point, maybe it's helpful for people to tie it into the what we did with the framing questions as well, to kind of tie all that together, everything we've done so far. David, did you want to add something to that?
So I think that's perfect. The only other part I might suggest for the chair's consideration is we have 3 categories left. If anyone wanted to send us their thoughts related to these 3 categories, it could help move us along a little bit, but I yield to you on.
Yeah, I think that's a great idea. I mean, I think as we get ready for the meeting on the 27th, look not only at the categories, but the categories in their entirety, because I think there is some intentional overlap that we built into this, and if you have some, clarifying views or simply questions, put them down in paper and share them with everyone. One thing that we haven't done is the notes from the last meeting. Are they available, David?
They're on the website.
They're on the website, and
Yes.
if you have a moment, please take a moment to reflect on those. Our notes from this meeting should be up in about, what, a week? That's a week yourselves.
By the end of the week, yeah.
Okay. All right. With that, I want to thank everyone for their participation tonight. It's been, I think, a valuable hour and a half from the standpoint of our staff. I want to thank everyone who participated, and also want to call out, all of our staff who have, spent a lot of time, as well as Friedman Health, both Vinayak and Mary Jo, in putting this meeting together. We'll look forward to seeing you in about 2 weeks. So everyone have a healthy evening. The sun is still out, I think. So we can still enjoy a little bit of sunlight before we end the day. Take care.
Bye-bye.
Bye-bye.
Thank you, everyone.
Thank you.
Bye.